12:45. Can you hear me out there? Can you hear me now? I see some old faces out there. It's going to be a lot of old faces today. Welcome to welcome to our monthly Metro Atlanta Trauma Advisory Committee meeting. Our topic today, title is Right Patient, Right Place, Right Time, Origins, Evolution, Destiny of the MTAC and the North Carolina Trauma Care System. I don't think there's anybody more appropriate to speak on this topic. I could probably say this, sit here for the next 10 minutes and introduce our speaker, but I'll try to hit a couple of quick highlights. Starting with the fact that as of July of this year, this will be 40 years at this institution. So I'm sure there's a number of people in the audience that are not even 40 years old. Some of us were really young, and other of us were not so young. But 40 years is a long time, and I think that's, if you look back through the history of this institution and the trauma system in the state of North Carolina, there's been a tremendous evolution of trauma care, and I would argue that the system of trauma within the state of North Carolina is probably far ahead of many states. One of the really novel characteristics about the North Carolina state trauma system is the collegiality of the trauma system within all of the trauma centers, and coming from a state like Pennsylvania, where it was tooth and nail and constant arguing and advertising and battles back and forth that we're better than you are, working in this state has been remarkable, and that's actually helped the trauma patients themselves for that. So our speaker, Dr. Michael Hale Thomason, has been a part of that from the very inception of the trauma system within the past 40 years. And trauma in the late 70s was sort of coming around, but in the 80s, when trauma systems really started to evolve, Dr. Thomason began to play a significant role into that. And I hope you'll see a lot of where we've come through, and I'll make it very clear that Dr. Thomason has played an integral role of that within the state. That being said, he has chaired multiple committees from the local, state, regional, and national levels, being a committee chair on the American College of Surgeons Committee on Trauma. He has a number of very appropriate publications, and several of them have impacted trauma care across the country, which I think is very important. He has also authored a book chapter in a very prominent, prestigious textbook in the past as well. But anyway, look forward to this discussion. There will be a tremendous amount of history here, and I just want everybody to realize that Dr. Thomason is very much a part of this history. Thank you.
Thank you. Appreciate it. Thank you. So I want to thank Kelly for pushing me to do this. It's kind of my swan song here, and you'll hear more about that as this goes on. I also want to thank him for making, on the spur of the moment, this challenge coin for MTAC. I just gave him the presentation yesterday, and already on here is Right Patient, Right Place, Right Time. So thank you very much for making that happen. It's okay. So throughout this talk, I'm going to try to give credit, and I'll forget to give some credit to people that preceded me. We all have those folks, the shoulders that we stand on. And the first one of those is Don Trunke. At least my recollection is that Don Trunke was the first one that either said or published this, Right Patient, Right Place, Right Time. I'm sure many others have said it too, and that dates back to the 70s. He's a trauma surgeon who's actually one of the icons and grandfathers, or godfathers, I guess you might say, of trauma. So the idea is the patient that has the injuries goes to the right appropriate location, not always to the trauma center, and gets there in the right time so that their care can be delivered life-saving if necessary, or expediently and safely. So I'm going to try to talk a little bit about the origins. As Dr. Singh said, I think I was actually here at the inception of the North Carolina trauma system, which is a little bit daunting. I'll talk a little bit about how it's evolved over the years, and then I'm going to talk about what I think the destiny might look like. This is my opinion. It's not Atrium's opinion. It's not MTAC's opinion. It's my opinion. So please don't hold anybody else accountable if this doesn't come out the way I intend.
I'm unable to take your call.
So first things, we think of trauma, this is what we think of. No disrespect to our emergency medicine colleagues, but when you poll the public, they all think they have a trauma center right in there, down the block from them. We actually did this in North Carolina about a decade ago, and it was pretty frightening that most of the public said, yeah, we've got a trauma center, and they would name it, and it would be whatever their local emergency department is, including urgent care centers. So emergency departments are an integral part of this, but they're not the standalone that makes up a trauma system, or certainly not even a trauma center. So that was a public perception that was causing them to rest easy that everything was fine for them. And you'll see as we go through this why that might not be such a good idea. The other thing that happened back in the beginnings is we were so focused on trauma centers. It was a big deal. Trauma centers were vetted. It's the first place that the American College of Surgeons Committee on Trauma turned when they started looking at verification. It was trauma centers, not trauma system. And the word that's used now for that, it was an exclusive system, meaning exclusively about trauma centers. And that was your destination of choice. And it really just ignored all the other care out there, except probably for pre-hospital folks. But everybody else was kind of, pushed to the periphery, and it was all about, are the trauma centers available, are they timely, accessible for patients, and so forth. And fortunately, as time went by, it became very apparent that they, in fact, weren't, that not every place had a trauma center near enough by to provide the kind of high-level care they needed. So we had to sort of evolve a bit, and we'll talk about that as we go through as well. This is sort of the next evolution of this, and this is a continuum or a system of care. One reason I like trauma is that it's not a standalone thing. It's always about the team. And those of you in this room and those of you on Skype represent members of that team that are indispensable to the successful care of patients in a trauma system. It may not be true in other specialties, but it's absolutely true in trauma care. And it starts from prevention, which we hope to do a better job of as time goes on, to the pre-hospital caregivers, to the 911 system, to our basic EMTs, to our paramedics, to our firemen, to everybody out there providing care in the field. And then it goes to the acute care facilities, but it's not just the high-level trauma centers. It spreads across all levels of trauma care, and we actually have 4 levels that are designated or actually verified nationally now. The state of North Carolina only designates 3, but in some states, level 4s are a prominent part of the trauma system because they're remote, rural areas. That's the only place you're going to get care. They're almost like a glorified doc in a box, but they're tuned up to do initial basic life-saving care and then quickly move the patients that they encounter to the next level of care as needed. Another thing that we tend to neglect because it's not quite as glamorous is what about the post-acute care? Our rehab colleagues, what about getting people back into society, back to work, back to school, a really important part. And then for secondary prevention, the things that we learn on the front end, like it's a good idea to wear helmets when you're riding a motorcycle at high speed, we need to translate it more appropriately and better into prevention efforts on the back end of that. So, trauma centers are part of a much larger system that represents the whole continuum of care. It's really a network, and it also is important in an inclusive trauma system to realize that we coexist with lots of other centers and facilities that aren't trauma centers and never having the intention of being. But we need to figure out a way to better integrate them into the overall care of patients, and I'm going to talk a little bit more about that as time goes on here. I don't expect you to be able to read this, but this is the wheel that stands behind every trauma system. It basically shows how the trauma system approach mirrors public health. It starts out with an assessment of the situation that you're dealing with in any different locale, and they're customized to every different place across the country. What happens in New Hampshire or Texas is not what happens in North Carolina or Montana, so every system has to analyze its own strengths and weaknesses and develop a plan, and that's the second phase, is development of where do we go with what we've got. And then the third phase is to continue, evaluate, assure, approve, improve, transition care, improve care as time goes on, and the circle continues on. So the idea is this is not a static program. Just like healthcare is not static, medical knowledge isn't static, trauma care is not static either, and there constantly need to be attention to new ideas and new ways, and we'll talk a little bit about that towards the end, I hope. So let's look at us in terms of what does MTAC provide. So regional trauma systems are part of a larger system, which in the case of North Carolina, we have a statewide trauma system, and you'll see in a few minutes how many racks we have. Most of you that are in this room probably are already well aware of that. But let's talk a little bit about what the regional trauma system consists of. So again, it mostly starts in the pre-hospital environment where the 911 call comes in and our first line providers go to the scene and they have to triage and stabilize those patients, and then there has to be active communication and then transportation to an appropriate facility. And that's sometimes is where the excitement starts. Where is that appropriate facility? Do those patients meet criteria to go to the nearest trauma center and, oh my God, bypass the local hospital, which sometimes is unheard of for all sorts of reasons? Or are they okay to be taken to the nearest hospital first for an evaluation and then, if necessary, stabilized and transferred. So in an optimal situation of an inclusive trauma system, every acute care facility would have an understanding about what their role was in this. They would have an approach to those patients that triggered an initial assessment when they rolled in the door, the ABCDEs of trauma care, and then a rapid decision about, does that patient need further imaging, do they need consults, or they just need to be load and go to our nearest trauma center, wherever that is, that can receive the patient. So things that are normally taken care of in emergency departments: broken arms and legs, broken ribs, lacerations, minor concussions. You'll hear a little bit more about this later, because that's not what always happens, at least not in our region, and from talking to colleagues around the country, not there either. Hospitals that aren't trauma centers at any level sometimes are very fearful of managing even what we consider to be pretty minor injuries, and they end up overwhelming the trauma centers and the trauma system in their area. So that's a point of contention that we'll talk more about. So that patient from the first hospital is either going to be discharged home for outpatient follow-up with someone, or they're likely to be transferred to wherever the available trauma center is. And that's an issue that's evolving in North Carolina as well, because of the word capacity. We're all challenged with capacity issues. You're boarding how many patients in the emergency department today? Who knows, at any given moment. And we're not alone. Wake Forest Baptist, Duke, Chapel Hill, East Carolina, Asheville to the west, all trauma centers run capacity challenges almost continually now. And so sending that next relatively minor patient to that facility, probably not in the patient's best interest, or the families, or the systems. So that's going to be an issue we're going to talk a little bit about. If they do get to the trauma center, the idea is they have high-tech care there, usually for multiple injuries and very serious injuries, and then the aftercare of that will either involve rehabilitation or discharge to home. And that's another whole area of contention that we'll talk about. What about the patients that don't have any funds? What about the ones that need rehab but can't have access to it? What about the ones from across the state line that we'd like to be able to care for, but their rules are different, and trying to get those patients back into a reasonable aftercare facility or a plan can be a real challenge. So patients end up staying weeks or months in the trauma center, occupying beds that acute patients need, because they really have no safe place to be discharged to. So this circle looks great on paper, but there are all sorts of barriers in the middle of that as well. Just briefly, if you're not aware of what the different levels provide, the level one is usually the hub of the hub and spoke situation in any regional trauma system. It could be a level two, but they're the highest level of care available. They usually have a significant number of admissions of people with high injury severity scores. They have a panel of surgeons, which frequently now are in-house 24 hours a day, and they also have all the surgical specialties that are needed: emergency medicine, general surgery, orthopedics, neurosurgery, and anesthesia teams, and lots of other subspecialists, hand surgeons and eye surgeons and all sorts of things that are needed to take care of this population of patients. There's usually a resident training program at different levels in there, and there's responsibility for ongoing research, for coordinating the injury prevention programs in that region, and for other kinds of outreach. Level twos are fairly similar, but they're not always in teaching facilities, but they still have to have the same cadre of physician support, more or less, especially if they're a lead hospital in that area. And there are many areas in the country where the level two is clearly the highest level of care, available for sometimes hundreds of miles. So they're a very important part, usually in less densely populated areas. Level threes are able to manage almost all injured patients initially. They tend to have transfer understandings. I don't know that we have written agreements anymore with their local level one or level two in the region that helps them figure out where does that patient go if they exceed my capabilities of caring for them. And ideally, they have guidelines that help them understand who they can keep. I will tell you that's going to be one of the challenges that I'll talk about in a few minutes, because those aren't really written down very well, and it's really sort of dealer's choice, and it varies by every individual facility and provider, which leads to lots of inconsistency and no standardization right now. They do need to have continuous general surgery coverage. I know my colleague Mike Behringer is here somewhere. He represents Atrium Cleveland, now level 3 center, just one example. So they have to have, there you are right there, they have to have 24/7 on-call general surgery coverage, and all level 3s are required to do that. One nuance about level 3s is progressively some of those places also have other specialty support, orthopedics and neurosurgery. And if you choose to have neurosurgery as part of your team, you have to meet the same criteria that a level 2 trauma center does. But you're not obligated to do that as a level 3 trauma center. You don't have to have neurosurgeons as part of your team. Even if they practice at your facility, you can choose to not manage neurotrauma, but you need to have very clear written guidelines about how you're going to manage those patients. As I said, level 4s aren't designated in North Carolina. We actually had a pretty intense discussion about this over the last few years. I don't think that's necessarily a done deal yet. It's a lot of effort on the behalf of the regulating agency, OEMS, and I'm not sure that it's necessary, but it's up for discussion. Nationally, the American College of Surgeons does verify level 4s in some states, as I mentioned. This is a little bit of the history of the trauma systems nationally in the United States. So you can see actually internationally, if you go back into the 1700s, and most people have probably heard of this gentleman, Larrey, he developed the first ambulance. This was in France. I think it was during the Napoleon times, if I'm not mistaken. And the idea was to not just let people limp and walk off the battlefield. It was actually put them in some sort of conveyance, a wagon, and take them off the battlefield. And before this came along, the concept was if you were badly wounded, it was up to you to get yourself off the battlefield, or your friends or your colleagues. And you can imagine how many people died along the way trying to struggle back to some kind of care. So back in 1797, this concept first came to pass. Interestingly, during World War II, the first civilian trauma center opened in Birmingham, England. A lot of the things we learn about trauma are necessitated by warfare and the urgency of the moment, and I'm assuming, though I know little about this, that that's exactly what happened there. There was the battle, battle of the Blitz of London and bombing and lots of civilian casualties, and my understanding is that's probably what prompted this. The first specialized unit started appearing in the United States in the 60s. Where's Dr. Jacob? Shock trauma, I think, was R. Adams Kelly, 1960, if I'm not mistaken. It was in the early 60s. Cook County in Chicago is another one of those places. LA County, hospitals in New York. So the very first specialized trauma units began, and as I said earlier, the focus was on trauma centers, not on trauma systems at that point, probably because that's pretty much where everybody went anyway. So they didn't have to worry too much about sorting patients out. They all just went to the high-tech hospitals or the high-acuity hospitals. The state of Illinois, again, where Chicago is, began designated trauma centers in the 70s and actually were the first to try to establish a system of care that was supported by state legislation. Whether they got any money for that from the state legislature, I don't know. I'll tell you that answer in North Carolina, and it's zero at this point in time. But they developed a trauma system. And then at the national level, the Emergency Medical Services Systems Act came into being in the 70s, and the College of Surgeons got involved in this, as they did in ATLS, and they published resources for optimal care of the trauma patient. The first one of those documents actually focused a lot more on ambulance care and equipment that needs to be carried in ambulance. That's the origins of this. And nowadays we can't imagine that being the focal point of their efforts, but that's where it started. And that's evolved since then. We're now on the Orange Book and moving on to the next version, whatever comes next. And then nationally, probably the biggest boost to this was the Trauma Systems Planning and Development Act in the early 90s that actually created a division of trauma and EMS within DHHS. And you'll see that North Carolina followed on the heels of that fairly quickly. And then HRSA came out with its model trauma system planning, or actually a reissuing of that in the early 2000s. So this is a really quick look at some of the pictures out of history. I borrowed these from Peter Fisher, who many of you know, our colleague here, is now back at his hometown in Memphis. But he did a similar talk not too many years ago, and I stole this slide from him because I thought it was pretty cool. So this probably is not too much advanced from what Larrey used in the Napoleonic Wars, basically a wagon that was pulled by a horse, and you toss the folks in the back, but they do have a red cross on the side of it. I guess that means something. But there was a surgeon named Depage, who was a Belgian surgeon that actually came up with this idea of triage in the field and advanced that in World War I. Still, it took them somewhere between 12 and 18 hours, if you lived that long, from the time you were injured to get to some sort of definitive level of care at a battlefield hospital. World War II made progress with that. Resuscitation became something that we actually started looking at. They would carry plasma. They actually had IV fluids. They were able to use fresh blood donated by soldiers. Motorized transportation came into being there in the form of ambulances like you see in front of you. And they actually decreased the transport time by over 50%, somewhere between 6 to 12 hours to be able to get there. Korea, anybody remember MASH? Anybody born when MASH? One of my favorite shows. And so helicopters came into being there as a means of transport, and that was a huge advance. So you can see what they actually did, not like we do. Where's Med-Center Air? I hope we don't do this now. Right? We just strap the dude on the side, on the outside, the injured patient. There's usually one on either side for balance, as I remember, if they could do that, and off they go. So that's a MASH helicopter in Korea, and they ended up in field hospitals like this, which is the Mobile Army Surgical Hospital. That's what MASH is. And the care was exceptional compared to what it had been previously, many more lives saved, and they cut the time down again, 2 to 4 hours from the point of injury and into a field hospital where the MASH surgical teams would work. Vietnam just further refined that. Helicopters were refined, more advanced. Another interesting thing is long-range radios. It didn't occur to me that that may not have existed effectively in Korea, but it allowed people at the point of injury to immediately call for help to stations that were set up. I have a colleague that I played tennis with who was actually a dispatch officer in Vietnam, and he told a lot of interesting stories about being on the receiving end of those calls and how he had to make judgments about whether to dispatch a helicopter into enemy fire and sort of things like that. Yeah, but they got immediate notification, so that cut down. Paramedics, or medics that were there, at the bedside, at the patient's side, not at the bedside, but in the field, became a real thing then and very much evolved. O-negative blood was being used for the first time, or non-cross-match blood, and that was an advance. And then again, the time cuts down. Injury to surgery within an hour in Vietnam. And then the various Middle East conflicts, what have we done there? Huge advances again, and I mentioned earlier, most advances in trauma care come during wartime. And then the other problem is they're quickly forgotten when it's peacetime. And that's something we're going to get to in a few minutes towards the end of this talk, is what do we do about that, and why does that happen? So rapid evacuation, damage control in field hospitals, in forward surgical areas was a critical piece of what was an advance taking place there. The use of all sorts of hemostatics. Tourniquets are reborn. Tourniquets were developed a long, long time ago, but they'd fallen out of favor. But they were re-energized by the people in the field and saved a tremendous number of lives. And one small example of things that are promoted by the military and then have evolved into civilian practice here. So I think nationwide now, tourniquets are being used routinely in civilian trauma and are saving a number of lives. So tourniquets were reborn. Flying ICUs depicted here. These are huge transport planes that were basically totally converted into ICUs. So they not only had rapid evacuation from the site of injury to their field hospitals, but back one more and then into launch stool for the most part within hours, certainly within 24 hours from the point of injury, initial stabilizing surgery if needed, whatever took place there, and then to a point of definitive care back in Germany. And these transports were an essential part of that. The other thing the military came to realize is they really were not doing collectively a great job of organized trauma care. There was a lot of one-offs taking place. There was no cohesive or coherent command about the medical care for injury. So they created the Joint Trauma System, or JTS, and they adopted the Institute of Medicine's concept of a learning healthcare system. And we'll get to that a little bit more in a minute. The idea is that it's continually evolving. It's not static, and you take lessons learned almost at the moment, or certainly within days or weeks or months, and you translate it into changes in care to improve care. And it's a constantly evolving process. And the military was able to implement that again with a huge number of lives saved. Having said that, though, what about preventability? Well, in Afghanistan, the case fatality rate decreased over 50% in the 8 years from 2005 to 2013. That was in the face of increasingly severe injuries. So that was a pretty dramatic accomplishment. But when they looked at the actual deaths, they found that at least 1,000 service members had died from what were considered potentially survivable injuries. This was based on gathering all the information in each of those cases, intensive peer review by military surgeons and other specialists, and their decisions were that about 1,000 of those had injuries they possibly could have survived. 25% of those were in the pre-hospital arena, 50% were in hospital. And so I've not served in the military. Where's Dr. Thomas? I know he's in here somewhere. But not every surgeon that works in the military is a trauma-trained general surgeon, correct? They could be urologists or any number of different specialties, I guess. So they're probably faced with those challenges out there on the front lines, and the people that were trying to provide the care are kind of learning on the job, I would guess, and learning from their peers. There's nothing wrong with that if necessity is the mother of invention, but that was a system that probably led to some potentially preventable deaths. And it may also have been the organization. Maybe it was the time interval. But what they also found is the cause of death in over 80% of those patients was, this is a test question on your quiz, 5 questions. The answer is hemorrhage leading to death. Hence the tourniquets being resurrected as just one example of things that you can learn on the fly that you need to do differently than you have been doing, implement those changes, and then see the results. So 80% of those people bled to death. That's not something we think of happening very much in a civilian trauma center nowadays, though it still does occasionally. But that was alarming. The other thing is that a civilian meta-analysis published in 2014 basically mirrored that. About 20% of hospital, not necessarily trauma center, but hospital deaths are attributed to potentially survivable injuries. That's an alarming statistic as well, and also speaks of our need to continue to evolve trauma systems nationally. Okay. So hold that thought for a minute about potentially preventability. How does that fit into our trauma system in North Carolina, to MTAC itself, and to the nation? We're going to get back to that in a few minutes in the future. So quickly to look at North Carolina's history in this. In 1973, the Emergency Medical Services Act, again, kind of mirroring what was happening at the national level, created the Office of Emergency Medical Services. And then went on to go through state trauma center designation guidelines that we mostly adopted from the American College of Surgeons guidelines at that time. Dr. Wayne Meredith, who's a colleague at Wake Forest Baptist, and myself and a few others were part of that process. Mike, I don't know if you were part of that or not at that time, but we put those together, and they actually went into rule in legislation in the state of North Carolina and became our trauma guidelines. So then we had a way to judge trauma centers for designation by defined criteria that actually had a national basis. And then in 1993, the Trauma Systems Act, again mirroring what was happening nationally, OEMS was then designated for the first time as the lead agency for the trauma system in North Carolina. Not until 1993 did that happen. Before that, back into the, I guess it was the 80s and early 90s, we had a trauma registry task force. And that meant that those of us from trauma centers around the state that were running trauma registries would get together periodically up in Raleigh and talk about things that we were doing and taking care of. And Dr. Singh mentioned earlier the collegiality that was fostered by those sort of efforts. We weren't, frankly, directly competing with each other for the most part because of the geography of North Carolina, which is a good thing. We mostly didn't have centers in each other's back doors like they do in New York City. So we all got along because we weren't competing with each other for the patients we were taking care of. Actually, the National Trauma Registry software was essentially created by Dr. Robert Rutledge, who was a University of North Carolina Chapel Hill professor and headed up the North Carolina Trauma Registry, and that was ultimately adopted by the College of Surgeons and became the NCTR through lots of other evolutions. And we published a great deal from that, and it was very unique nationally because most people weren't doing it. So we combined our efforts across the state with all the trauma centers that were existing, and we would publish a significant number of things that pretty much got us on the map nationally as a state and a state trauma center. And that was a big leap forward. And then in 2003, we sort of coalesced what would have been the registry task force to make it a little bigger initiative, and it was the State Trauma Advisory Committee. But note that it's only in an advisory capacity, and that's how it is today. It has no regulatory authority. It has no accountability directly. It has no specific designated responsibilities from a legislative or a rules point of view or statute. And that'll be important as we talk about things that might need to change to make us a more effective system going forward. And then in 2004, we requested through OEMS a trauma system consultation that was relatively new at that point in time by the American College of Surgeons Task Force. So they came into the state for 3 or 4 days. Many of us went to testify. It was held up in the Research Triangle, and they put together a report out of that, and I'm going to show you just a few of the highlights of that. And even though it's, on 15, 20 years old now, there's a lot of things that are relevant in here that we still need to address today. So here were their key recommendations. Unify the trauma clinical leadership to champion a state trauma plan. Again, we were collegial, but we weren't all unified about where we needed to go with this. Lots of different opinions about what direction this should take. Should it be inclusive, exclusive? What about all the places that aren't trauma centers? How do we include them? So that was their first recommendation. Appoint a trauma surgeon as an advisor to the EMS medical director. Up until that point, the EMS medical director was kind of a standalone, was frequently an emergency medicine physician. They had trained there, may or may not have had any experience in trauma. That was a real sticking point for trauma centers because this individual was regulatory responsible for them along with the OEMS staff. So that was a recommendation, and I ended up becoming the first and to this point the only trauma medical advisor, which is a job I'm going to continue on at least for the next year or so. And I think it made a big difference because the voice of trauma centers and trauma surgeons was blended with OEMS. We have a very collegial relationship with them. I hope I've been a bit of a bridge for that. Dr. Tripp Winslow is an outstanding individual, emergency physician up at Wake Forest Baptist, is the state trauma medical director, and he and I have a great working relationship. So that's been a big step forward, and it was catalyzed by that recommendation. Would have never been considered had that not come to pass. Define and evolve the governance and reporting structure of the RACs. I would have to say, where's Kelly and Dr. Singh? No offense, but that really hasn't evolved very much. We've got RACs. They all function. I think they get along with each other, and we'll look at those in a minute. But there's no defined regulatory authority, statute, or rule in state government that dictates how this has to work and what's supposed to happen. So it's pretty much a voluntary effort, and those of you that are in the room know that for the most part. Develop standardized EMS guidelines for triage and transport of injured patients to community versus trauma center hospital. That has taken place. So we have the triage and destination guidelines now. Every EMS agency has to have those. They have to be approved by OEMS and Dr. Winslow, and I think that's a big step forward. And it actually catalyzed a couple of hospitals that were not really considering whether they would be part of a trauma program or trauma system to reconsider that. And I'll give you a specific example of that because, candidly, they were at risk of being bypassed if they didn't step up and provide the service that their community needed. And that was a good step forward, I think. So that recommendation was adopted. Establish the triage criteria and destination protocols for an inclusive trauma system. And again, I would say we're not there yet because we really have no authority to tell the hospitals that are non-trauma centers what they have to do with their patients. They're not at any particular risk except liability risk if they choose to keep patients they shouldn't keep or, frankly, send patients they should have kept. So it works both ways, and we don't have any authority or response or ability to enforce, our guidelines in that way right now. I think that's another point of evolution. The hospital status system tracking capability. Unless somebody can tell me different, Jenny, you may know different from this. If the state has one of these, it doesn't function as far as I can tell. I may be like in flu season or in hurricane disasters, you're supposed to call up somewhere like a couple of times a day, Kim, is that right? And report in. I don't know how often it's supposed to happen. Is it daily or hourly or is there a standard for that? Yeah. Yeah, it doesn't help any. It maybe lets them catalog what the availability would have been like 3 days earlier, but this is supposed to be real time. Believe it or not, the state of Louisiana, I think, has actually got a functional system. I think they have a centralized dispatch situation where they have such a call center. They have status reports that are real time on all of their facilities, and they're able to make strategic decisions in real time about destinations for patients that are acutely injured. At least that's an article that they published not too long ago in the Journal of Trauma. We're nowhere near that in North Carolina. So that's a challenge for us, and we can do a lot better than that. The technologies obviously exist. Nobody's put the money in to do it. Utilize our premise system, which is our pre-hospital EMS run sheets, if you will, and other data sources to identify trauma patients managed at non-trauma facilities. There are things like UB82 forms and other sources of data, but we really haven't taken advantage of that in any meaningful way, and certainly not for any real-time monitoring of what's happening to patients at all the other non-trauma hospitals, and there are a lot of them, obviously, and what are their outcomes? Are they better than ours? Are they worse? Who knows? So that's something that we've definitely got to do a better job of. 14, 15 years ago, that was a recommendation. We haven't been able to do that to this point. And then develop a statewide and then at least a regional RAC system PI plan. I think we do PI at the RAC level, but I would say it's not systematic. It's certainly not necessarily consistent across all the RACs in the state. There's no cohesive plan for how we do that. What you monitor, how it's reported, and what we do with that information. So we've got a lot of work to do there. And then to develop a statewide trauma research consortium and link it to the STAC. I'd say we actually have done that in the last couple of years. Dr. Jacobs is in charge of the STAC. He's the state chair of the Committee on Trauma. I think that not just through the TQIP collaborative, but through our research efforts, we actually have a monthly meeting now. Lots of people call into that. We have a number of projects, some of them around pediatric trauma, and we're all collaborating on that using state trauma registry data. So I think in the last couple of years, we've resurrected the use of our state trauma registry for these kind of things, and hopefully once again can have both a regional, statewide, and a national impact with information that's going to come out of that. So we currently have 8 RAC regions. Again, I think I'm preaching to the choir mostly in here. You all know this. The things that are in statute about what we're supposed to be doing as our RACs are outline, establish, maintain a coordinated trauma system throughout the regional level with broad input from emergency medical services, hospital, and community input. In my experience over the many years of doing this, the people that are always at the table are our EMS providers, our firefighters, our emergency medicine physicians, our nurses, our docs. And I hope there aren't too many administrators in the room. If you are, I'm sorry if you're offended, but you can look far and wide for administrative high-level support at the RAC meetings, and they're usually not there, in part because it's not mandated in any way. We really had them establish the rules. But if things get done in facilities, you obviously have to have a team that's the administrative team and the clinical team working together. And though we do that individually, we don't have a systematic way to do that at either our MTAC level or at the state trauma system level. So that's something that's sorely missing and I think is much needed. And again, there's no animosity specifically, it's just mostly apathy at this point that I think we've got to do better at. So again, here's our map. It says January 2017, but Kelly, take a quick look. If I'm not mistaken, it looks the same right now across the state. So the level 3 centers are in yellow, and the level 2s are in blue, and the level 1s are in red. One of the things that I think we're very proud of here is that we have 4 of the 5 level 3 centers in the whole state are right here in MTAC, and that's something we should be pretty proud of, and I'll talk just briefly about those in a minute. The other thing that the team that came in 2004 pointed out as they stood back and looked at this map, which looked a lot like this now, and they goes, who drew this? Kind of like the whole gerrymandered election maps, right? Who drew this? And their point was, coming fresh into North Carolina, is who would have ever drawn that? Who would draw a blue way down there and up here? So where do you think that evolved from? How did this map evolve to begin with? Anybody have any idea? It's where hospitals send their patients. And the best example is a Duke blue. Any Duke people here? Dr. Moorman here? Okay. Basically, again, no offense to them, but that's where they had populated those counties with their graduates. So they were Duke affiliates for all sorts of reasons. So the one down here in the far south, Robinson County, a lot of Duke grads had gone there to set up practice. So that's how those things were established to begin with. It's where the referrals came from, not necessarily for trauma, but for cancer, for heart disease, for stroke, for all those kind of things. So it's basically a mosaic. So you could argue that the West and the East look pretty much like they probably should, kind of because Asheville and Greenville are the only shows in town. There's not anybody else competing out there. The middle of the map, we're not too bad off here. Actually, Forsyth up there where Wake Forest and Greensboro aren't bad. But when you get over in the triangle area, it's a mishmash. And so their point was, whoever drew that map needs to go back and redraw it. But that's where consultative advice is helpful, but it doesn't deal with practicalities. So nobody's going to start changing those referral lines overnight. So we're kind of making do with what we've got. The one good thing that did come from legislation, though, is that every facility has to designate a RAC that it's going to be a member of. And those are allowed to change from time to time. And you'll see that when you look over here, 4 of our counties have split allegiances based on which hospital is in it. And again, based mostly on their referral patterns that are long-standing legacy patterns. That doesn't necessarily impede our ability to have a system, but it probably is not the way you would have designed it if you had done it from scratch. This is just a quick look at where we are right here. And one of the things to point out that's true of states that I've surveyed across the country is the state boundaries don't mean a whole lot. Again, same idea. Patients go the most expedient place and where legacy situations have developed. And I think that's important to acknowledge. So Piedmont Medical Center is a level 3 trauma center in South Carolina criteria, which has now adopted the American College of Surgeons criteria exactly as we have in North Carolina. So it's going to be interesting to see how that evolves. But Piedmont sends us a fair number of patients that exceed their capabilities, and that's appropriate because of the geography. The next closest thing for them is Columbia, which is down south, or if you go further to the west, Spartanburg, Greenville. So we're in the corridor, and it makes sense. So we have absolutely included them, and I don't know if there are any South Carolina folks either on the line with Skype or here in the room, but we very much value what you guys do. You're part of our team, even though the state legislation doesn't specifically include you because you're in a different state. But from a practical point of view, they're very much a part of MTAC, and we want to make sure that continues, and absolutely true for all the EMS agencies that are there in the northern part of South Carolina. And our catchment area goes pretty far over to the east. We get patients from Bennettsville, Cheraw, Chesterfield from time to time, and also to the west, obviously from Chester and Clover, and sometimes even points further west. So these are our level 3 trauma centers that are here now. There's Claremont, which is up in the upper left. There's Northeast in the right. There's Novant Presbyterian just to the right. And there's Cleveland in the left lower corner there. Those are our 4 current level 3 trauma centers in MTAC, which we are extremely proud of, and I think are huge contributors to our coordinated system that we actually have in place here. So what about the challenges? I think that one of the things that you don't recognize if you live in Charlotte is that North Carolina is still a rural state. I think by definition it's still a rural state, even though you can look at the population centers there and it's not too surprising. Asheville, Metrolina area, you've got Greensboro, Winston-Salem, then you've got the Triangle area, then you've got Greenville, North Carolina, and then you've got Wilmington down at in the southeast. In spite of that, half the population resides in what's rural zip codes, and about half the population takes longer than 45 minutes to reach either level 1 or a level 2 trauma center if they're badly injured and need that kind of care. And that's a challenge for us. Other challenges. So what I try to do is kind of color code here, and it probably doesn't come out as well, but my point is there are a number of different systems represented in our MTAC region. The 2 that we're most aware of are Atrium and Novant, but there are plenty of others. In the South Carolina hospitals are 2 different systems down there, and it's constantly in evolution. So it's a real blending of different hospitals, and though I don't think that necessarily leads to open hostilities, it certainly leads to competition at times, and it makes it difficult for the frontline people to always get together on where we're going to go with care, because our business interests may go in different directions, and that's just reality. So the political and business side of this is interesting, and with all due respect to the Rainbow Coalition, this is what we look like a lot of times here, and that's not unique to us. If you go to any other state in the country, for the most part, you're going to find the same sort of of issues, and they're not always rising to the top, but I can tell you I've been in a number of review situations where there was frankly open hostility, between neighboring centers competing for patients. Again, I think we're very fortunate in North Carolina. We don't have that at this point. I hope it continues that way, but this is something that's a challenge for us as we continue to try to evolve a cohesive trauma system, right patient, right place, right time, patient-centered. Do we do this? Do we do it well, and do we do it the right way every time? These are my ideas. Again, it's not MTAC's, and it's not the state for sure, even though I'm the OMS Trauma Medical Advisor to the state. I disclaim that immediately. It's not Atrium's ideas. It's Mike Thomason's 40 years worth of looking at this ideas. So one of the things that's still a sticking point for us is the trauma system in North Carolina is an unfunded mandate. Pennsylvania has a foundation, I think Maryland, Florida. There are a number of states that have been able to get this through legislation with either traffic violation money. Georgia has done a fabulous job of this, millions of dollars directed to the trauma centers and their trauma system, and it shows. They've done a great job of evolving and developing this. North Carolina, no specific dollars dedicated to the trauma system. Those costs are pretty much borne by the EMS agencies, by the individual hospitals, and that's the way it is right now. We had hopes when the recession hit, we'd actually mobilized a whole task force that was going to make a presentation that Dr. Bering will remember, Dr. Jacobs may remember at the state level. That all went on hold back in 2008, 2009, and has not been resurrected. Capacity is a huge challenge. We alluded to that earlier. The people on the front lines here can testify to that on an hourly basis. And one of the problems that we have is other hospitals in our statewide system have the very same challenges. We don't have any requirement that if you're the lead hospital in your RAC, that you must take a patient and transfer from another facility within your RAC, even if you have capacity challenges. So frequently, we have smaller hospitals out there just on the line dialing. Kim can probably tell you that from the PCL line's point of view, trying to find anybody that'll take their patient. Now, we're not talking about field transport. Everybody will take a patient from the field, I think. There's very little of that going on. But once a patient lands in a facility that's a non-trauma center and they can't be cared for there, it's a dial-a-thon sometimes to try to figure out who's the first person that'll say yes. And that's a huge challenge on both sides, on the receiving side, on the sending side. And in my personal opinion is that if you're the lead hospital in a RAC, you need to accommodate patients from facilities that are in your designated RAC. That should be your obligation. But as I said earlier, there's no legislation that requires that. There are no rules that require that. It's basically volunteer. And it's on your own decision making as to whether you do that or not. At the very least, I think if you can't accommodate that patient transfer, you ought to be a facilitator to try to get that patient to the next appropriate location, wherever that may be. We're not required to do that either, and that really doesn't happen all that frequently unless it's done on a voluntary basis. So I think that's a huge challenge for the state trauma system. We're going to have to figure a way around that. The North Carolina Trauma Registry doesn't provide any kind of state denominator for trauma. They noted that back in 2004 when they did their systems visit. People with severe injuries probably are being treated at non-designated hospitals. Maybe they have great outcomes. Maybe they have terrible outcomes. We don't know unless it ends up in litigation somewhere, or unless the patient in a delayed fashion gets transferred to one of our trauma centers in renal failure, in septic shock, or something like that, that we then get a tip of the iceberg sense of what those patients are. So the truth is, we don't know. And if you're going to be a cohesive system, that's information we've got to have, and we don't have that right now. So the data exists out there, but the ability to link that data together, which is the last bullet point there, has not yet come to fruition. We've been trying to link pre-hospital data with trauma registry data for what, Mike, anybody? 20 years, 25 years, forever? I mean, that shouldn't be a technological, overwhelmingly challenging task. We still haven't been able to do it. And we manage both those databases. The state manages Premise and the North Carolina Trauma Registry. There's no common identifiers that we can come up with at this point. We haven't been able to pull this off. It seems like a rudimentary thing. If we're going to study trauma in its continuum, we still can't do that. Okay. I've mentioned this already. I'll emphasize it one more time. There is no statutory requirement that all hospitals participate. They have to sign up for a RAC, but they don't have to participate. They don't have to follow any guidelines, even if we put them out there, or suggestions or recommendations. And what that leads to, as I mentioned earlier, are things on two sides. One is people with minor injuries that the local people feel, for whatever reason, that they don't feel comfortable with and it exceeds their capabilities, gets sent to the trauma centers, which overwhelms the trauma centers. And I'm talking about mild concussions, single rib fractures, tiny little pneumothoraces that are occult on CT scan. Those frequently prompt transfers. Maybe that's just expedient and convenient. In their defense, it's hard to find a provider in those hospitals that are willing to admit those patients. Frankly, community surgeons don't usually see that as their responsibility. Hospitalists are frightened of that for whatever reasons, or it's inconvenient or whatever. I don't know, but concussions, really, those don't need to be at a level 1 trauma center, but that happens fairly routinely, as those of you on the front lines can testify to. That's something we're going to have to figure out how to fix. That won't work if we're truly going to be an inclusive system. It violates the right patient, right place, right time dictum that we're trying to do. It's not very patient-centered because patients and their families are put completely out of pocket for long rides that they don't need to have. Often to be told when they get to the place of their destination they don't need to be in any hospital, and we need to discharge them home from the ED, and that creates some ill will and bad feelings. And so all of that is something that we're going to have to continue to evolve as a state, in my opinion. The RAC and the STAC, as I've already mentioned, have no clearly defined authority within our state trauma system at all by legislative statute, and I think if you're going to have a cohesive state trauma system, that's ultimately going to have to change. I've already beat up the tracking system enough, so I won't say anything else about that right now, but we might want to take a look at, believe it or not, Louisiana, and see what they've done well, and think about whether we can implement that or emulate that here. Here's the last one that's pretty important. How many of you are involved in disaster planning, disaster management? Nationally, everybody talks about surge capacity. What do you think our surge capacity is here at CMC today? I'd say probably 0. And again, talking to colleagues, even at Duke, but certainly at Wake Forest Baptist, at Wake in Raleigh, at East Carolina, they don't have any surge capacity either, except their ED, and we just continue to board patients. So if we had a true disaster here that required an immediate response, we got nowhere to put these people that are badly hurt right now. We would make do in some fashion, but we really aren't planning for this. But it shows up in all the documents. If you're part of the disaster, right, Jenna? You show up in the disaster planning meetings. We talk about surge capacity and what we're going to do about that. We don't have any for our tertiary centers. It's non-existent at this point in time. No defined statewide trauma system evaluation or PI plan. Again, we do this individually on a voluntary basis in our individual RACs and our own trauma centers. There's not yet a cohesive plan for how to do this across the state. And there's actually no statewide consensus or any regulation about which patients should stay in which facilities, which I've spoken to several times already now. Not only that, on the back end of care, there's no guidance for repatriation of patients. So on the front end, if you take badly injured people that come here and need life-saving care, when they no longer need that, but they still need care and they don't have anywhere to go and they're unfunded, what do we do with those people? We can't send them anywhere. So they are overwhelming our system. They are long-term stayers and boarders in the high-level trauma centers, and the local hospitals have plenty of bed capacity, but politics and finances and Medicare and all the other things that get in the way of that are impeding our ability to get patients back, right patient, right place, right time. So convalescence could easily take place, much more benefit to the patient and the family to be 2 miles from home instead of 40 miles from home. We really can't figure out a way to make that happen consistently yet. Another thing, just as an aside, is the Rural Trauma Team Development course was a great idea. I've delivered a few of those. I'm not sure the impact that's having. I don't think it's having a very positive impact. It's really hard to get physicians to those. It's usually, again, the emergency medicine services providers and the nurses there that are showing up for those courses, and I'm skeptical that it's having any major impact. So we need to reevaluate that and see if it should be part of a statewide trauma plan, and if so, how are we going to change it to make it better? And then the lack of really any statewide coordinated injury prevention planning. What we should be doing is taking all this data that we're collecting from our trauma registry, looking at very specific injuries like falls, and then looking at targeted interventions, and then most importantly, looking at the effectiveness of those. So we have a lot of things we do in injury prevention that are really laudable and appropriate and lots of effort and energy. We don't do a great job of measuring the results of those. We're doing that in some rudimentary ways, but we're not doing it in any consistently high-level way to help us see, are we doing a good job of this? Which leads to this. All right. So I know that time is up, right? You're supposed to give me the 5-minute warning. Sorry. Okay. So I will very quickly go through the future and apologize in advance for keeping you over time. So this is the one thing I wanted to tout, and I won't go into great detail on it here, but this was the National Trauma System Initiative. This was the National Academies of Science, Engineering, and Medicine put this together. I went to the kickoff for this about a year ago. In all the years I've been doing this, and we've tried about 4 or 5 times to create a national trauma system, I've been completely discouraged. This has a chance to fly. I don't know if our military folks are here or not. I didn't see Dr. Thomas here. Dr. David Calloway, he and I spoke yesterday. He's heading up that initiative here. So the Department of Defense has really taken the initiative here. They are moving ahead with this to the point where I think in August we're going to have a pilot program, if I'm not mistaken, here. I guess it's from WOMAC in Fort Bragg, and it will involve emergency physicians, nurses, nurse, medic, radiology tech, lab tech, and that's just the beginning, because hopefully over the next couple of years we're going to roll out a 10-person team that will be embedded here with us in our trauma team for periods of time where they'll get frontline training. And the purpose is, of course, as we mentioned earlier, in times of warfare, they're getting plenty of on-the-job experience out there. But when it's peacetime, all that goes away. And so they need a way to have sustainable training in high-level trauma centers that see combat casualty level care, at least from time to time. And that's what we're committed to as a system to help provide that. So we've got a great relationship moving forward there. I would encourage you to look at this. Interestingly, I looked this up. This book costs $75 if you want to buy it online. It costs $60 if you want an ebook. It is free if you want to go online and just download the PDF, which is what I did last night, 500 pages. There's great stuff in here. Nobody's going to sit and read this through, but as you're looking to be part of developing a trauma system, either here in MTAC, at the state level, or at the national level, I'm going to tell you just briefly why I think we're well positioned to do that. I'd encourage you to go. Just Google a National Trauma Care System, those words, it'll pop up. It's the National Academy's publishing, it's nap.edu, and it'll be on there for a free download. So if you have any interest in this going forward, if you're going to be involved in the system planning or system care, I encourage you to look at that. The unique concept is, for the first time, this tries to integrate military and civilian trauma systems together with the very high-level goal of 0 preventable deaths, both military and civilian, at the end of this project. So they picked a high mark just because they wanted to get people's attention. There needs to be a federal agency that's assigned responsibility for that, and there's active work going on to figure out where that might be right now, to set in motion common standards of practice, data standards, research, workflow across the whole continuum of care, and this idea of a continuous learning trauma system, which is well outlined in this book, and I won't go into any more detail with that right now. This is the general concept, patient in the center of this, and all the things that need to surround the patient so that you get real-time information about how your care is being delivered, whether it's Reboa that we're talking about, whether it's the use of tourniquets, whether it's how we take care of minimal brain injury patients. So we're evaluating that in real time going forward. And as we learn things, those are very quickly put back into practice patterns with standards of practice that will change and need to be adhered to, and everybody on the same page with those. That may be a pie-in-the-sky, concept, but that's where this is aiming and headed. So what about North Carolina? Us in North Carolina, we that are stakeholders, we're really well positioned to be leaders in this for all the things that we talked about over the last hour. We've got a system that's existing. We have a collegial system right now that works well together and is pretty collaborative. We have 2 high-profile military bases right here, Womack Army Hospital at Fort Bragg, Special Operations, and Camp Lejeune down on the coast, just to name the 2, and they are actively pursuing trauma center designation. I'm going to go to Camp Lejeune in about 2 weeks to look at their North Carolina designation. They've already been designated or verified by the College of Surgeons as Level 3 Trauma Center, which was really fast-tracked, and I think Womack's looking at the same thing. So we have that advantage. We're going to have an integrated system. I've already mentioned the pilot program that's actually starting this August, and that's been fast-tracked, I think, Mike, is that correct? It wasn't supposed to be moved up that quickly, so it's now on the fast track as well, thanks to the military. Those things we've already talked about. OEMS is a good partner in this. That's not true in every state. In some states, it's the public health department that runs the trauma program. Sometimes there's controversy and animosity. We really are fortunate to have a pretty good working relationship with our regulatory agency, which is OEMS here. The spirit of cooperation and collaboration we've already talked about. We have current databases if we can just get them to talk to each other. And if somebody puts some money into it, I think we can do that. And I think that we can develop our North Carolina TQIP, Trauma Quality Improvement Project, statewide collaborative that's gotten off the ground recently into what would become this learning trauma care system. We have the infrastructure starting to develop to do that, and I think we have interest in that at the state level, and so I think we can continue to move that forward. And then I think the inclusion of other time-sensitive care, this may be anathema to trauma surgeons, but we need to look at this, or we're going to have a coalition going forward with any hope of funding at the state government level. How about stroke? How about STEMIs? Other things that are time-sensitive. How about critical care? A lot of those issues are the same issue. Right patient, right place, right time. Whether it's the virtual critical care initiative out there, trying to help sort that out, and acute care surgery or emergency general surgery kind of falls under that same umbrella of time-sensitive, people with dead bowel that are in shock, that need care at the right place in a timely fashion. So we might want to think about going forward into the future, coalescing all of these things under one umbrella. It runs some risk of diluting trauma out, but it may be the way that we get to where we need to go as far as getting some support. I wanted to end by acknowledging Norm McSwain. Those of us that are trauma recognize him as a trauma icon, at least I do. He's associated with New Orleans and Charity Hospital forever, even though he didn't spend his whole career there. He was an integral part of creating this. He was on the task force that put this together, and that was the quote that's in this book. That is something he reportedly said every day to anybody he encountered. What do you think about that? So I think each of us could ask ourselves that question as we go forward each day, and that's at least in part what this has all been about, what most of us are about that are part of trauma care in MTAC and in North Carolina. So thank you for the opportunity. I'm concluding, as Dr. Singh said, July 1, I walked in the door as a relatively green new doctor, scared to death intern. At that time in the emergency department here, there was only one doctor in the emergency department after 10 p.m., one doctor in the whole emergency department, and it was the intern on duty. So we've evolved, thankfully, from that. So I consider myself all of those things below. And then thanks to Dr. Matthews, who's over here, this is the next phase of where I hope to go. And I don't know where that'll lead me, but I'm glad to have been here. Thank you.
We're out. Again, for us, I think is Dr. Jake.
I'd like to take this opportunity to publicly thank Dr. Thomason for all of the years and the dedications that he has provided to the citizens and to the medical community in Charlotte and beyond. He used the word collegial many times during his presentation, and I think a lot of that owes to him, not just across the state, but certainly at this institution. Many of us who come from other places have been struck by the relationships that we have with emergency medicine, orthopedics that don't exist in other trauma centers, and I ascribe that entirely to Mike's leadership, his temperament, and his vision. So I just want to take this opportunity for all of us to please give him a round of applause.